Hello and welcome. I'm Shelley Gunther, sonographer and clinical marketing manager at Clarius. We're excited to see so many of you join us here today for the live webinar titled Ultrasound for Facial Aesthetics, Mastering Ultrasound Anatomy. And backed by popular demand, renowned facial plastic surgeon Dr. Stephen Weiner will be describing facial ultrasound anatomy as it relates to facial injections. Now, this webinar follows our ultrasound basics webinar that we did in January, where a few people asked for more anatomy, so we're delivering. Now, Dr. Weiner will share step-by-step instructions for using wireless ultrasound to identify facial layers, including vascular structures, to help you achieve safer and better outcomes for your patients. And we'll also see some live scanning with the Clarius L20 HD3 following Dr. Weiner's presentation. And before welcoming our guest, I'd like to welcome all of you. You're among just under 3,000 avid learners who registered for today's popular event. Thanks so much for joining us from all corners of the world. And a quick housekeeping note, please use the Q&A box on your screens at any time during today's webinar, as there will be a live Q&A session following the presentation. Now, I have the pleasure of hosting the webinar today, and I'll be doing a live demo immediately following Dr. Weiner, so stay tuned to see the Clarius L20 in action. And just before we begin, I'd like to share a couple of papers I read preparing for this webinar. And not surprising, there are more and more contributions each year on the topic of facial aesthetics and ultrasound use for that matter. And this is an abstract from the Journal of Plastic Reconstructive and Aesthetic Surgery Journal in 2023. And it discusses the increasing popularity of perioral rejuvenation with dermal fillers and the associated complications. And while most issues are mild and manageable, serious complications like vascular compromise and infections and delayed onset nodules can impact aesthetic outcomes and require invasive treatment. So this article outlines strategies for prevention and management, including safe injection techniques and ultrasound guidance for vascular mapping, filler assessment, and treatment. Practitioners must understand injection anatomy and how to prevent, recognize, and manage complications effectively. And this next paper is a narrative review of the consensus statements of expert practitioners and various literature on the injection points and techniques. And this review mentions the merits of ultrasound-assisted and guided botulinum toxin injections in all areas of the face, including the importance of visualizing the masseter muscle prior to injection. So you're going to get a really good look at all kinds of ultrasound anatomy today. So just before we start, let's put out a little poll just to get to know you and where you're at in your ultrasound journey. Now, do you use ultrasound in your practice today? Are you using it daily, occasionally, not at all? Or are you just learning today? So just give a couple of seconds here. 3, 2, 1. Wow, so lots of learners today. So this is fantastic, but it is good to see that there's several people that are using ultrasound. Excellent. All right. And poll number 2, for those of you who are using ultrasound today, what are you using it for? Are you just doing vascular mapping, or are you just using it to learn facial anatomy a little bit better? Great. We'll give a couple of more seconds and you can choose as many as you want here. 3, 2, 1. Excellent. So lots of vascular mapping, guided injections. That's excellent. Okay. Good. Well, I think you'll really find this beneficial, just confirming your knowledge of ultrasound anatomy in the face. So let me introduce our guest. Dr. Weiner is a board-certified head, neck, and facial plastic surgeon. And after graduating from UCLA, he completed med school at the University of Michigan. He interned and completed his residency at Johns Hopkins, where he became an instructor for 2 years in the Department of Head and Neck Surgery and Facial Plastic Surgery. In 2005, he laid down his scalpel, concentrating 100% of his efforts in non-invasive and minimally invasive cosmetic procedures by founding the Aesthetic Clinique. Dr. Weiner maintains an extensive lecturing training schedule and is one of the top physician trainers for Galderma Train the Trainer events. He's the founder of Sonosthetics, an ultrasound training course for the aesthetic injector. And Dr. Weiner is a board member of the CMAC, which educates on the prevention and management of filler complications. And he is also the director of the Ultrasound Academy for Injection Anatomy, a monthly 2-day course on cadaver and ultrasound anatomy and injection techniques. So do look for one of Dr. Weiner's courses and workshops in your area. All right, so without further ado, Dr. Weiner, I will hand the mic over to you.
All right, so I'm Dr. Weiner, and I'm going to run you through some anatomy and some injection techniques. And I can't do the entire face. I did the entire face on video, and that's available in the Clarius library. So we're going to go over the key anatomic structures today. I just wanted to point out that I did recently complete a textbook with my colleague, Chris Surik, who's an anatomist and plastic surgeon. And so he goes over the anatomy using diagrams, and then I do a correlation using ultrasound. And I want to point out that we were rated #1 at Amazon.
Right. The next area of evaluation is the temple. It's my favorite area because it's a very complex anatomy. There are several different layers. So the way I like to evaluate the temple is not quite horizontal and not quite vertical. It's sort of in an oblique fashion. So it's paralleling the orbital rim. And I like to do it this way. Remember, when you hold the ultrasound, make sure that part of your hand is actually touching the patient. It allows you to make fine movements. So let's go through the anatomy here. So the very deepest aspect is your bone. That's down here. The next layer is going to be your temporalis. Keep in mind that there is no periosteum on the temple bone. So here is your muscle. This is the temporalis. The next layer is going to be your deep layer of your deep temporal fascia. That's right there. So the deep temporal fascia actually is one layer that splits into 2 layers. It splits into a superficial layer of the deep temporal fascia and a deep layer of the deep temporal fascia. And in between those layers, there's a couple names for this fat pad. I like to call it the intermediate temporal fat pad, but it's also called the superficial temporal fat pad. And that's right here. So, and then this layer here is going to be your superficial layer of your deep temporal fascia, which is right there. Now, you see a little black area just above that fascia. That's called the interfascial plane. And that's right here. And then superficial to that is going to be your superficial temporal fascia, or your temporal parietal fascia, or your SMAS layer. So that's right here. And then superficial to that, it's going to be subcutaneous tissue, subcutaneous fat, and skin. Right here, and then skin's above here. So let's see the T mode in this area. And let's see how accurate I was. So here we go.
So the T mode is going to be your AI
So let's
mode.
look at the T mode images. So deeply you see the bone, then you see the muscle, then you see the fascial layer, then you see the fat, then you see a superficial layer of the deep temporal fascia, and then you see a purple layer, which is the interfascial plane. So the T mode is really good to help you navigate the anatomy of the temple. So let's look at the vascular structures of the temple. Let's go back into your B mode here, and then power Doppler. And so there's basically superficial vessels and deep vessels. So let's look at the superficial vessels. So there's the anterior branch of the superficial temporal artery is usually in the inferior temporal septum. And the inferior temporal septum runs from the superior orbital rim to the root of the helix. So it's not always, but usually in a line like this. So therefore, I like to place it somewhere in that area. Oh, well, what do you find? doing this search, I came across that deep temporal artery. So here we go. So that's the deep temporal artery right there. So the deep temporal artery, this is the anterior branch. There's two branches. There's an anterior and a posterior. The anterior branch is going to be right near the orbital rim. It runs along the temporal bone. And that's actually at risk when you're doing those deep injections. So I highly recommend doing vascular mapping before you do the deep injections in the temple to look for this deep temporal artery. And in this patient, it was very close to the injection point that you like to use for this one up, one over technique in that deep area. So while I was doing this examination, the patient did remind me that she had surgery because she had a pseudoaneurysm of her superficial temporal artery from a trauma case. So I'm not going to find that superficial temporal artery on this side. So we can take a look at this side. So interesting, I was able to get both of the arteries in one screen. And let me show you that. So right here. So this is the deep temporal artery, anterior branch right here. And this is the superficial temporal artery more superficially. That superficial temporal artery lies in the SNADS layer or the temporal parietal fascia or the superficial temporal fascia. Those are all the same. So we found all the necessary vascular structures of the temple, that deep temporal artery and that superficial temporal artery. That concludes the evaluation of the temple.
So again, you can find this video along with all the other structures of the face. I did the forehead, tear trough, which we're not going to be doing today, jawline as well. And let's go to the next slide here. So these are from my textbook. And you can see the superficial temporal artery. It's lying in that superficial temporal fascia. Here's that intermediate temporal fat pad, temporalis, and then the bone. Okay. So in this case, I'm using the color Doppler, but on the other, I was using the power Doppler. I'm actually making a transition, and I'm mainly using the power Doppler because I'm not too concerned like you would be in the carotid artery or the jugular artery or something about the velocity of the vessel or the direction of the vessel. I'm more concerned whether I'm finding the vessel or not. And power Doppler is going to give you more sensitivity, give you more artifacts with the power Doppler, but it's more important to know if there's an artery there or not.
Yeah, the power Doppler is so sensitive to any movement, right? Because it's looking for really low flow. So yeah.
So yeah, you can't have the patient talk during this.
Right.
And every little movement of the probe you might see some artifact. But you can determine artifact from real as if the pulsation is constantly in the same area. If it's constantly in the same area, it's most likely not an artifact. It's most likely the artery. These are two vascular structures which weren't mentioned earlier. These are the venous structures. And the sentinel vein empties the superficial venous structures of the temple. And we see them often just beneath the skin. And it brings it through the two layers of fascia into that middle temporal fat. And in the middle temporal fat, you have the middle temporal vein. Okay, and how can I tell that's a vein on the right side? What I'm doing is I'm actually compressing it with my probe, and you can see that it goes away. And now you can compress an artery as well, But if you're compressing very lightly and it goes away, it's more likely to be a vein than an artery. So this is a way that you can get into the interfascial plane. And let me just explain this. I'll put it on pause for a second. So what you do is you go and you feel the temporal crest. And that's the little ridge here. That's where the temple meets the forehead. You go a little bit medial to that, 5 to 10 millimeters medial, and you make your pilot hole. You then go down to the periosteum. Now, the periosteum of the forehead is contiguous with that deep temporal fascia. So if you're running along the deep temporal fascia, you're going to automatically be in that interfascial plane. So now I'm going to confirm it with the ultrasound. And I used large cannulas here, 23, 22 gauge, because they're safer. And you see the cannula right in here. And you see it's in the interfascial plane. Here is the superficial fascia, and I'm going to inject a little bit, and you see it filling up that interfascial plane. Now, a little trick that I do is often what I'll do is I'll inject a little saline before I inject the filler. And by injecting saline, if you're not in the correct plane, it's not a big deal. But it also expands that interfascial plane because sometimes the two fascias are very close together and very hard to separate. So the saline actually separates that out. So I want to show you what it looks like after filler. And this was a demonstration patient, and they got injected with HA filler, needle down into the bone in 2 different areas, one here and one there. And take a look, the filler does not stay on the bone. This is because there's a phenomenon called backflow, and I'm going to show you that a little later, where the filler goes the path of least resistance after you start injecting. And the path of least resistance is back up the needle or the cannula. From Dr. Swift, I think he said around a needle, you get around a 30, 35% larger hole. And around a cannula, you actually get something around a 70% larger hole. So you're going to get more backflow with a cannula than with a needle. So anyways, those are what HA looks like, and they're in the temporalis muscle. And then I injected Sculptra in the interfascial plane, and you can see that it's separating. This is that superficial fascia, temporal fascia, and this is a superficial layer of the deep temporal fascia. This is that intermediate temporal fat. But look what's over here. That's that anterior branch of the superficial temporal artery. And you see that it's in that superficial fascia, superficial temporal fascia, just as I described earlier. So over here, what you see is, is a nodule in the temple. So what happened here? This patient was injected deeply with a needle onto the bone with PLLA, Sculptra. And you see on the ultrasound, there's actually a collection of the PLLA in the interfascial area, subcutaneously. So as I described earlier, this is due to that backflow phenomenon. And because the muscle and bone don't really create much collagen, the collagen was created in that subcutaneous area and in the interfascial plane. So when she clenched her teeth, you saw the nodule. A complicating factor here is the patient actually was pregnant, and so she didn't want to have medication for this, and she wanted a very simple remedy. And what I did is I told her and she was a nurse injector. So I recommended that she try to break it up mechanically using a needle or a cannula. And she did so. And you see on the right side, this was a week later, it completely resolved. So I do recommend for most PLLA, as well as calcium hydroxyapatite nodules, you try that at least once. And it usually resolves the problem.
The next area of evaluation is the cheek, and you can evaluate that in both a horizontal and vertical fashion, which I will show you. Remember to keep the notch to the patient's right, but when you're doing it in a vertical fashion, keep the notch superiorly. So the main structures of the cheek are going to be your infraorbital foramen and artery, your deep cheek fat, your SMAS, and your superficial fat. So let's make sure you're in the cheek reset, and I want to show you some anatomy here. All right, so the first thing you see right here is going to be your maxilla, your bone, your cheekbone. This next area here, that's going to be your SMAS layer. So the SMAS layer is pretty distinctive. It's going to be hyperechoic because it's full of a lot of collagen. And then above that, you're going to see your superficial fat pad. Notice that the deep fat, which is right here, is actually a lot darker. And so there's differences between the deep fat and the superficial fat as far as consistency. The deep fat doesn't have as much fibrous tissue to it, so it's going to be more globular. It doesn't have as much structure to it, and it's going to be darker. It's going to be hypoechoic. But the fat that's superficial right here, it's going to have a lot of fibrous tissue to it, so it's going to be a little more echogenic, so it's going to be hyperechoic. So this proves that fat can be several different echogenicities, and so don't let that fool you. So some fat could be dark and some fat could be light. If you look along the bone here, you see that this patient actually has some HA lying along the bone. And in my opinion, I think that the filler in the cheek should be placed deeply along the bone for best results and best longevity. So let's look for the infraorbital foramen. So that's going to be a break in the bone. So the typical infraorbital foramen is going to be 8 millimeters from the orbital rim in the midline, mid-pupillary line. So we see it right over here. I'm trying to move it into the middle of the screen. It's going to be right here. So you see that there's a small notch in the bone, and that's where the artery and nerve come out. So we can confirm this by using the Doppler, the vascular. So although it's not a strong signal, it seems to be very consistent in this area. So this is the infraorbital artery. And that's in the exact area where I told you that the foramen was as well. And you can actually see it coming out of the foramen right there. So that's the infraorbital artery coming out of the foramen. So let's look at it in a vertical fashion. Remember, keep that notch upward. Let's see if we can find that notch. Right there. There we go. So at this point, this is the infraorbital artery. I'm going to show you a little better view of it right there. And you can see that there's a break in the bone. So here's the bone here, here's the bone here, and you see the artery coming through that foramen. And what's interesting to note is that the infraorbital foramen from superior has a little roof on it. And you can kind of see how this right here creates a roof. And so that protects the foramen when you're coming from lateral or superior. But when you're coming from inferior, which would be from the right side of the screen, you can actually get into the foramen very easily. So the vertical position shows that roof a little bit better than the horizontal. So again, the anatomy here, here's the bone, the maxilla. Here is the SMAS layer. Here's the deep fat area, which is going to be a little bit darker than the superficial fat, which is up here. So what I'd like to show you now is the T mode of the cheek. And it's really cool. It shows you the anatomy. Make sure that that notches patient's right. And as I described earlier, I'm going to show you here is the T mode over here. So I showed you before what the SMAS looks like. So the SMAS is going to be right here. And I showed you what the deep fat and the subcutaneous fat look like. So it's spot on, just as I told you before, without using AI. Good job, Clarius. So that concludes the evaluation using T mode of the cheek.
So I want to show you something that's actually not very commonly seen, but it's the zygomatic cutaneous ligament. And so that ligament runs from the tear trough area, and it runs along the inferior border of the zygoma and goes up to the zygomatic arch. And it separates above. The deep fat would be called the SUF, and below would be the deep medial cheek fat. So what a ligament looks like are these horizontal stair-stepping hyperechoic areas, and they run from the bone all the way up to the skin. That's what a ligament does. So if you look on the superior aspect, remember this is vertical, so superior is going to be on the left side. This is your medial SUF, and on the inferior aspect of that ligament is your deep medial cheek fat. Also, you can see very clearly here that there's a little hood to that infraorbital foramen that I described. And you see the little break in the bone here, and a break in between. Also noted is that the infraorbital foramen is noted to be inferior to the zygomatic cutaneous ligament. And if you've seen discussions before about the prezygomatic space injection, which I'd like to use, that is above the ligament. So that prezygomatic space injection, which is above the ligament, below the SMAS layer, protects you from entering that foramen and harming that nerve. So I want to show you something interesting as well. Again, you see that little hooding of that infraorbital foramen, which was right there. But you also see a very anechoic structure lying right on that. So what is that? That's actually HA that was placed above the infraorbital foramen. This could end up giving the patient some pain, pressure, and discomfort. But in this case, it was just a benign finding that I found on routine exam. If that were to be causing problems, you can dissolve it or dissipate it with saline. So this is a case of an infraorbital artery vascular occlusion. And you see on the left side that there's a distribution in the area of the infraorbital artery, but it also goes up to the lower eyelid because there's something called a palpebral branch of the infraorbital artery, which goes up to the lower eyelid in the midpupillary line. I want you to note on the right side of the screen is her capillary refill. And you see that the capillary refill is borderline. It's about 3 seconds, which is borderline. Okay, so that was factored into how I took care of this patient. Now I'm taking a look with the Clarius, and over here on the left side of the screen, you see some HA down into the bone. But over here is the infraorbital foramen, and this is the infraorbital artery. And you see it's kind of discontinuous. My explanation for this, not 100% certain, but was that there was some spasm in the artery. I'm not a believer of external compression. I believe that there was some filler within the artery causing this. So there's the filler right there in the infraorbital foramen. So what did I do? So just to take a step back, this patient was actually in one of my anatomy courses. She was a nurse injector. She had been injected the previous day. So I was going to see this patient for another 48 hours. And she's a very good patient. She knows if things are going bad. So she was injected minimally with hyaluronidase, 75 units, given aspirin and steroids. And then I saw her the following day. And the following day, you can tell that she looked a lot better. Okay. Her capillary refill was better. The redness was better. She was feeling less pressure. And then I did the ultrasound. And the upper ultrasound is what she looked like before I treated her. And then the lower is that next day. And you see that there's much better flow in that artery than there was initially. So at this point, I think we're on our way to recovery. And I gave her a little exosome topical therapy. And she sent me this photo the next day. And she was completely better. So let's go on to, this is dissolving of my tear trough area, my PA on the right, my nurse on the left. Now, this is one way to do it, and I recommend doing this for the early users of ultrasound, because it kind of gets complicated when you have to look at the screen, inject, and hold the ultrasound at the same time. I prefer to hold it myself now, but these people had very little experience using ultrasound and did a great job. They weren't hurting me. And you can see that the cannula that they're using is right in the heart of the filler. And you see on this, the before and after, that they nailed it. They got right into that filler and it got better.
So this is Dr. Steve Weiner. The next area we're examining is the nasolabial fold, the angular artery, and the deep piriform space. So I like to examine it this way, horizontally. Remember the notch to the patient's right. And what we're looking for here is basically the angular artery. And you want to see if the angular artery is laying on the bone or it's in the SMAS area, so off the bone. So this is mainly a vascular study. And we're going to look. And what we see here, the main angular artery is right here. And what I use as a criterion is I use if the artery is more than 1.5 millimeters off of the bone, then it's safe to go deep onto the bone with your injections. If it's less than 1.5, I recommend that you choose an alternative method, mainly using the cannula in the subcutaneous plane is a very safe way to do this as well. Why do I choose 1.5? Because the bevel on a needle that you're going to be using is typically 1.5 millimeters in length. So even if you're on the bone and you're below the artery, you possibly can have the bevel still within the artery if you are on the bone. So 1.5 is that criteria. And this is obviously a lot more than that. And I'll check a distance here. And you can easily check this distance. The bone is going to be hyperechoic, which is very white area. And so this distance is 4.14 millimeters. So it's very safe to inject deeply on this patient. So let's check out the other side. And I'll get a little more gel. And here we go. And on this side, you see the artery. It's a little bit closer to the bone. Let's see how deep this artery is from the bone. So we check the distance here. And this distance is 2.8 millimeters.
So this is what it looks like when you inject the filler down to the bone, and you see the artery is well away from trouble. And you can see that the artery is actually displaced a little bit. And, I'm not compressing that artery at all.
Hey, it's Dr. Steve Weiner, and the next area that we're going to examine is the pregal sulcus DAO inferior labial artery. That's right in the Marionette area. Make sure you have the notch pointing to the patient's right. And here I am. It's not quite as deep as the posterior jawline, so you can make the depth a little bit smaller. And the DAO is going to be the large spindle-shaped muscle, and you can ask the patient to frown. And you see that muscle gets bigger and smaller when she frowns. And let me just point that out to you. So this is going to be the DAO right here. And always just deep to the DAO muscle is going to be your mental foramen. And that's a little bit of a break in the bone. Hold on, let me move it over a little bit. And you're going to see a little notch in the bone. There it is right there. Let me just get it in focus. So we're looking at the mental foramen right now, and that's going to be right here. And through that mental foramen is going to be your mental artery and vein, as well as the mental nerve. Let me get a little bit better view of that maybe. Right there. So this is the mental foramen, and it's deep to the DAO almost always. So the other significant structure in this area is going to be your inferior labial artery, and that's usually deep to the DAO as well. So let's put on the vascular, and let's do the power Doppler. And we're going to look for that inferior labial artery, which is deep to the DAO muscle. I'm going to increase the gain a little bit. There it is. So what we're finding right here is the inferior labial artery. And you see it's deep to the DAO muscle. So here's the inferior labial artery, and here's the DAO. And the inferior labial artery is going to be the first branch off of the facial artery. So the facial artery is always going to be a little bit lateral to the DAO muscle, and I'll see if I can find that now. So inferior labial artery deep to the DAO right there. So now if I go a little bit laterally to the DAO, you're going to find, there it is, the facial artery. So DAO muscle here, facial artery right here.
So I just want to show you from my textbook. Here's a really good example of the DAO and inferior labial artery, sometimes also called the labial mental artery in this particular area. There's going to be a fat pad below the DAO, which is called the deep lateral chin fat. Just reiterating, here's the mental nerve. The mental nerve is going to be this isoechoic structure. It's going to be sort of a middle of the road gray color coming out of the mental foramen. And then, as I described earlier, the facial artery is always going to be lateral to the DAO. That's a constant. And then the superficial fat in this area is the jowl fat. I want to point out that the DAO has a relationship with the DLI. And what I'm doing here is I'm alternating between frowning and smiling. When I smile, the DLI is activated. When I'm frowning, the DAO is activated. But more importantly, I want to show you that there's an overlap between those two muscles. And that's where we get into trouble when we're injecting the toxin. So make sure when you're injecting toxin that you're doing it superficially and laterally.
So the next area of evaluation is the chin. Make sure you turn your preset to the chin and jawline area. So let's look at the chin, and One of the main things that you see in the chin is this midline raphe, and I want to show you it's right here. So this is an area, it's almost tendinous, it's where the muscle attaches to the bone. And on either side here, you see the mentalis right here and right here. And if you look really closely, sometimes you're able to see the ascending mental artery. Let's give that a try right now. So let's turn on the vascular, the power Doppler. And I'm going to turn the gain up. So I like to turn the gain up. Sometimes for these very small vessels, I turn the gain and I overgain it. And if there's too much artifact, I back it off. But these vessels are slow and they're small, so using everything to your advantage by turning up the gain. And what do you see? You do see the ascending mental artery. That's usually going to be right there. So it's usually 6 millimeters off the midline, and it's paramedian. Sometimes there's both a deep and a superficial. In this case, it looked like it was pretty superficial. Let's show you where it is, right there. So you see the midline is over here. So this is paramedian. But usually we're injecting in the chin, we're injecting deeply. So it's safe to inject deeply on this patient.
So I want to show you what a patient that has both the deep and superficial ascending mental looks like. That's on the left side of the screen. And I measured it, and it was 6 millimeters from the midline on this patient, which is textbook. What I want to show you here is a cannula, and this exemplifies the backflow phenomenon. I want you to see when the injection occurs that you're actually not injecting as much in the chin area as you are along the cannula. And therefore, it changed my injection technique because I wanted to inject through. So in the future now, I inject through that midline raphe, and that prevents some of that backflow. So in general, the anatomical knowledge is key for your best results. The vascular anatomy is highly variable. Ultrasound mapping will improve your safety and outcomes, and the T-mode will shorten your learning curve. So these are my training dates for sonosthetics, and the QR code will tell you. So I'm in Vegas next month, and then I'm in San Diego, Atlanta, and Miami. So now I'm turning it over to
Excellent.
Shelley.
Excellent. Yeah, thanks for including those dates, Dr. Weiner. We've got a few questions about education, and I'll just give you a quick little demo here using the L20. Okay, so yeah, I'm using the L20 here. Ooh, there we go. And just going to start. And something I want to show you just really quickly is it's new. It's called the aesthetics preset. So when we go into aesthetics, instead of having to go back in and select cheek, forehead, temple, piriform, or whatever, if we go into aesthetics, there's these nice little icons at the bottom that will automatically change your preset for you without having to go in and out of that menu. So I'm going to select the jaw preset here, and I'll start with the DAO, where Dr. Weiner was just showing me earlier how to find the DAO, which I believe is this right here. Is that correct?
That's it.
All right.
It's one of the great landmarks of the lower face.
Yeah, you can't miss it.
Yeah, and there's the the mental foramen. You just passed it.
Oh, right there?
No, on the left.
Oh, no, there it is. I think my depth is just a little bit too.
There.
Yeah, okay. Excellent.
Right there.
Okay, so if I turn on my power Doppler now, I think we tried this a little bit early in our little test drive, and I couldn't really see that vessel very well, but I think it's really tiny. Kind of seeing a vessel.
Yeah, you can see it now.
Yeah. I tell you, I think I just had maybe a little bit too much pressure on before.
It's a very small vessel.
Yeah. And so then if I go up a little bit higher, I'm going to try to find the inferior labial artery. And you said that's going to be just beneath the DAO, correct?
Yeah.
Or should be.
putting you on the spot here.
Yeah, no kidding, no pressure. I think I saw it there. I better grip on my, like Dr. Weiner was saying, you kind of have to anchor your finger on
There's
your
at least
patient.
part of it right there.
Yeah, part of it there. It's a little bit tortuous. There we
That's
go.
it. That's it.
Okay, excellent.
Yeah.
Good. And then if I just go again a little bit more lateral, we should be able to find that big facial artery,
There
which
you
is
go.
nice, big, juicy artery that is a good place to start with practice, right? If you're looking for vessels and you want to try to track where those vessels go.
So the facial artery and vein in this area, they do run together. So the vein is always going to be posterior to the artery. And you can also compress with the probe to tell if it's the artery or the vein.
So I think that's the artery because I'm pushing a little bit there.
Yeah, so that's the artery. Yeah, you're probably,
Yeah.
the vein is probably being compressed. It's easily compressible.
Well, there's pressure. I'm nervous. I can't hold still.
Let's look at the
Okay, so
piriform.
yeah, let's go up to the piriform. So I'll just change my preset here. And we'll just go right here.
And if I remember correctly, this patient had an abnormality in this area.
Yeah, yeah. So if I just turn on the power Doppler.
So without even measuring it, you can tell that this patient's artery is too close to the bone for safety.
Right.
It's less than a millimeter away. So in this case, you need to either do it under direct guidance, which is a little bit hairy, particularly for the novice, or just decide to inject it with a large cannula more superficially than on the bone.
Yeah, that's amazing.
Yeah, so and we don't have to go through it, but the other side was exactly the same.
It was exactly the same, right? Which they're not always. That's
No,
right.
it's actually quite unusual for both of them to be on the bone like that. Now, the literature states that it's about 4% of patients have it on the bone. However, newer ultrasound data suggests it's closer to 20 or 25%.
Wow.
So, also, I've been fooled a little bit. I hadn't seen some very small vessels. So in this particular area, you need to overgain it. And that will bring out the very small vessels, because what happened is it looked all clear. I went down to the bone and I did an aspiration and I found actually blood in the needle. And then when I went back, I found out that I had missed a small vessel. So overgain it there.
Yeah, yeah.
Safety.
Err on the side of caution.
Yeah.
Yeah, and I'll just do a little quick demo of T mode here. So it's in the modes menu, and here's your T mode down at the bottom. And so this just we're going to acknowledge that this is an educational tool. But yeah, there's our T mode. So it updates the anatomy in real time. And then when we hit the freeze button, it labels it for us. So it's a really nice educational tool if you're just starting out and having troubles kind of distinguishing what all of these little layers are on the ultrasound side.
Right. Ultrasound is all about visual recognition.
Right.
And
yeah.
if you weren't adept at ultrasound, it would be hard to make out this smash layer. But it's night and day for me. But newer people can't. And then there was a lighter superficial layer, which was the superficial.
Yeah.
Yeah.
Okay,
So
let me just switch back my
a lot of
camera
questions.
here. Yeah, tons of questions.
A lot about PLLA and
yes.
Okay, so it's very easy. Don't make it too complicated. Don't inject steroids or 5-FU. I would say that most of these can be taken care of with just injecting a little bit of saline and lidocaine just to create a numb environment. and take your cannula or needle, and then break it up, and you hold it so it doesn't move, and you just break it up. And if you have to do it again. I don't think I've ever had to inject steroids or 5-FU using this technique.
Dr. Weiner, I'm
yes.
going to just go through my little product pitch here before we
Yeah.
go into more questions. So bear with me for a couple of more minutes. We've got a survey that we'd like to put out there. So yeah, thanks for sticking by for the little T-mode demo here. You know, as you see, it just might be the little nudge you need to get you started recognizing the facial anatomy with ultrasound. So just before we go back to the questions here with our guest speaker, here's another quick poll for you. We'd love it to help everyone continue your journey into bringing ultrasound into your aesthetics practice. So complete this poll if you'd like any additional information. And just before starting the Q&A with our doctor today, I'd like to take a minute to tell you a little bit more about the Clarius L20 HD3. It's 20 megahertz wireless scanner, now 30% smaller and lighter, with an integrated battery, and it's available in several countries worldwide now and growing. So with the membership or the one-time license, you have access to educational T-mode and other advanced features that unfortunately I didn't have time to demonstrate for you today. Since the 80s, ultrasound has been recognized as the gold standard among plastic surgeons, but systems were always costly and complex. And so today, Clarius Ultrasound has changed the game in facial aesthetics. Miniaturization and innovation with handheld units means high-definition imaging is now easy and affordable, with image quality that rivals traditional systems, but at a fraction of the cost, representing a savings of well over 80%. The Clarius L20 HD3 is the only handheld ultrasound with ultra-high frequency to 20 megahertz for exceptional superficial imaging up to 4 centimeters for facial aesthetics. And with high definition imaging of the skin, muscles, vessels, fascia, you'll gain confidence in your needle placement, easily characterize and evaluate fillers, and accurately treat complications, improving patient safety with consistent treatment outcomes. Now, as you saw during the webinar and the live demo, Clarius is wireless, freeing up space with zero footprint. It's also fully immersible, so much faster to clean and disinfect as well. Only Clarius delivers linear wireless scanners with an ecosystem that includes a free app for your iOS or Android device with free updates, a couple of a year at least. Clarius Cloud is available to capture and manage your exams from anywhere. And we also offer Clarius classroom videos with experts and onboarding with Clarius clinicians to build your ultrasound scanning skills. Now we'll close off the poll, and if you didn't get a chance to ask for more information, you can still do so in the closing survey. So let's welcome back Dr. Weiner now to the Q&A session. And I want to let you know that a recording of today's session, as well as a PDF copy of the presentation, will be emailed to you in the coming days. So keep an eye on your inbox and keep those questions coming now. Okay, Dr. Weiner, let's get back to these questions here. Great.
So the name of the book is Atlas of Ultrasound and Anatomy, Facial Rejuvenation. It's available at Amazon. It moves on and off the best-selling list for plastics.
That's so great. That's so great.
Is T-mode available for L15, Shelley? I think
it is. Yes,
yeah.
it is. Yeah. It's available in the aesthetics presets. So if you have access to those aesthetics presets, you're going to have T-mode.
So when you're using T-mode, you must be in the areas, the presets. You have to be in the temple, the cheek, or the lips. Those are the only three that have T-mode currently. Yeah,
currently. Yeah. So the model has been changed on or trained on specific anatomy. So in order to recognize that anatomy and label it, it needs to know kind of what part of the face you're scanning.
This is recorded. So the dates for my training will be available on that. But if you look up Fundamentals of Ultrasound and then AMSPA, AMSPA, Google will take you to the registration area.
Excellent.
Let's see.
Good. There's one question about methyl methacrylate.
Yeah,
Similar,
methylmethacrylate.
yeah. Is it similar to, with silicone oil on ultrasound?
No, it's not. So silicone oil is, it's very distinctive. And methyl methacrylate is going to be, it's like PMMA. It's going to be like very hyperechoic and reflective. So it's going to be like Belafil methyl methacrylate. So that's what PMMA is. So they're going to be completely different. So silicone oil it's going to obliterate the anatomy. You're not going to see any anatomy whatsoever. So they're very different. Snowstorm is what people
Right.
call.
Yeah. Yeah. It's
silicone
it's
oil.
quite unmistakable, isn't it?
Yeah, it looks. You can't see anything, and the PMMA is going to be very hyperechoic. It's going to have posterior shadowing, which means the sound waves hit it and bounce back. They can't go through it. So they're very different. If you use, I didn't know you had an L17. Do you have it?
No, I think it's L7. Yeah.
Oh, okay. Okay, the L7 is not ideal for the face.
Yeah.
It doesn't have enough resolution, so I wouldn't use the 7. I don't think they have an aesthetics mode.
There's a question about visualizing the smaller retinaculum of the upper lip. Can you visualize that with ultrasound?
So you can see some hyperechoic areas in the subcutaneous fat. So what retinaculum cutis is, it's these fibrous collagen fibers that run from the SMAS layer to the skin. So when you smile, let's say for instance, the nasolabial fold, you're able to pull the skin because of these retinaculum cutis, these fibers. The resolution in the lip is going to be markedly decreased because it's a small area. You can see just a haze of hyperechoic area, but you can't see them individually.
There was one question about the which treatment did you put to the patient with a vascular occlusion in the infraorbital artery?
Basically, vascular occlusions are a spectrum. She had a very, very mild occlusion. And I didn't actually do the injection before, and I didn't actually inject her with the hyaluronidase. I had recommended, let's just follow it. The injector who performed the procedure she got a little nervous, and she injected 75 units. And I'm not sure if it helped or not. She didn't do it under ultrasound guidance. So in some cases, I'm not saying this is the standard of care, but in some cases, I actually have 2 or 3, and there's actually a paper out on another case where you can watch it. Keep in mind that that's not standard of care, and don't say Dr. Weiner says to watch all these. But if the symptoms are very mild, the patient is very reliable, and the patient wants to keep their correction, keep in mind you have about 3.5 days until you have skin deterioration and necrosis. So sometimes you can watch it. Sometimes I'll watch it in the office, for instance, and if it's getting better while in the office, great. I like steroids. They are controversial. I always do aspirin. That's not as controversial. And see the patient the next day. That's the important part. I think we're very much over-treating these vascular occlusions, and you traumatize the patient, and they get PTSD from all the needle sticks, and the injectors are treating themselves more than they're treating the patients. So just be aware that ultrasound has been proven to significantly decrease the amount of hyaluronidase you need for complications as well as vascular occlusion. It's a whole nother lecture.
Exactly. Well, we are just past the top of the hour, so I think to be respectful of everyone's time, we'll call it there. If there are any questions we didn't get to, Dr. Weiner will answer the facial aesthetics related ones, and I can answer the product related ones in the coming week. So please complete our closing survey to provide feedback so we can bring more educational webinars like today's. So to conclude, I'd like to thank you so much, Dr. Weiner, for your insights. It's such a pleasure working with you always. And a very big thank you to all of you for joining us. Have a wonderful day and keep scanning. Thank you.
Thanks a lot, guys. Bye-bye.
Bye.